Okay, now we're going to finish it off with a few quick ones here. So ischemic colitis is ischemia. It's the name kind of speaks for itself. It's ischemia to the colon, and the damage is often done in susceptible areas. The damage is usually reversible, and it's located in watershed areas of the colon, which we talked about earlier, the splenic flexure and the rectosigmoid junction. So again, here are the two regions that can be affected most by hypotension. The reason why that happens is because you have really high perfusion pressures right here, just off of the main arteries. But as you get deeper and deeper, more and more distal to these main supplies, this pressure here is lower. So if you lose all your systemic pressure, this region would be the first to get damaged from that. It's caused by either atherosclerosis, but more often than not, especially on tests, they're going to give you some sort of very obvious hypotensive episode. Like, guy comes in with, he has shock, they fix him up, he's doing okay, but now he's got all this bloody stool, then I want you to think ischemic colitis. So for atherosclerosis, you can imagine if you have a clot in one of your main arteries or just a plaque, then you'll already start with diminished blood supply in the first place. And so by the time you actually get out here, you're going to run into some problems. And likewise, for a hypotensive episode, if you don't have as much blood supply coming in general, you're just going to have decreased blood supply. And again, you can see who's getting affected most. It's these regions here: splenic flexure, rectosigmoid junction. This presents kind of like I just described a little bit ago. You'll get abdominal pain, bloody stools following one of these precipitating episodes. Okay, so for volvulus, I did talk about one of the types of volvulus in the small intestine lecture, and I'll revisit that here. Let's go over, there's three different types of volvulus. So a volvulus is a twisting of the colon around its own mesentery. And the problem with this is that if you're twisting that region of intestine, it can obstruct the bowel, and it could also lead to infarction of that segment. So here you can see a twisted segment around its mesentery. You can imagine that if a stool's trying to get in here, it could get obstructed. And also remember that the blood supply is coming on in here. And if you're twisting that blood supply, you can also get infarction of this region due to hypoperfusion. There's a few subtypes I want you to recognize. The most high yield by far is the sigmoid volvulus that occurs in the elderly. You can also get cecal volvulus in young adults. And lastly, you can have a midgut volvulus in neonates. So starting with the sigmoid volvulus, this will present with an older person with low abdominal pain, constipation, and lack of flatulence. And to diagnose it, you just need to get imaging studies and find this big coffee bean sign right here. Once you see that, you have your diagnosis. Here's some coffee beans, just so you have an idea. It kind of does look like a coffee bean. To treat this, you gotta do a sigmoidoscopy, and usually you surgically correct it. Now, cecal volvulus looks pretty similar, but I mean, you can see some differences. Here's the sigmoid again, if you wanted to see it. For cecal volvulus, it's usually seen in young adults. And what happens here is that for some reason, during embryology, the cecum is not attached 100% to its mesentery. And because of that, it has a little bit of mobility. And with that mobility, it can twist around itself and cause a volvulus. And here you can see, again, this huge, kind of like a coffee bean, but the location's a little different. And that's with a young adult who has a cecal volvulus. And the same thing, you can treat it. You either have to remove part of the colon with a hemicolectomy, or if you can reverse this torsion, you can actually attach the cecum back to a wall so it doesn't twist on itself in a procedure called a cecopexy. Now, midgut volvulus we talked about in the intestinal malrotation section. And so, again, this is related to malrotation, and it's because the lad bands can basically predispose the intestines to twist around themselves. So, what happens here is that in lad bands normally attach the cecum to the right lower quadrant. So, if this is our normal colon, lad bands can attach to the right lower quadrant and everything's good. The problem is that if you have malrotation, your colon your cecum might be in the right upper quadrant here. And so a lad band attaching to it could actually cause an obstruction, especially in this duodenum right here. It can cause an obstruction or a twisting, or volvulus in that region. So how this will present is bilious vomiting during the first weeks of life. You'll also get transient abdominal pain. You can diagnose this through imaging studies. You'll see air fluid levels on abdominal x-ray, which I talk about in the small intestine lecture, in the small bowel obstruction, what air fluid level looks like. And you have to treat this surgically as well, generally. Okay, I'm going to go over what ileus is versus Ogilvie syndrome. So ileus is a temporary loss of bowel peristalsis. It's going to affect both the small intestine and the colon. It's caused, there's a number of causes, but some of the common ones. Recent surgery. After recent surgery, some people can have an ileus. Certain medications can cause it. And for how this presents, it's going to be somebody who's constipated or obstipated. They're not going to have many bowel sounds because of this temporary loss of peristalsis. And you could easily develop nausea and vomiting and abdominal pain as this evolves into a small bowel obstruction. Ogilvie syndrome sounds somewhat familiar, but they'll give you some key differentiating factors on the question stem if they want you to pick this one specifically. So this is called colonic pseudoobstruction. It's typified by massive colonic distension, but no evidence of obstruction. And what I want to point out here is that the disease exclusively affects the colon, whereas in ileus, it affects both the small intestine and colon. Ogilvie syndrome, you're only going to see in very, very sick patients or in post-surgical patients. Okay, usually a hospitalized or nursing home patient is very common on the question stem because they don't want to trick you. They have to make sure that it's a fair question and that Ogilvie syndrome has to be the answer. If they give you a question with somebody who's kind of not that sick, I want you to not think of Ogilvie syndrome because they're going to give you a classic presentation if they want you to pick that. It's also associated with narcotic use as well. Okay, our last section here is just on a childhood disorder, Meconium Ileus and Hirschsprung disease. So Meconium Ileus, meconium is just a newborn's first poop. And so Meconium Ileus is just a lack of defecation within 24 to 48 hours of life. This is associated with cystic fibrosis. And the reason this happens is that in cystic fibrosis, there's usually a thicker consistency of stool. And because of that, the stool can actually create this meconium plug that obstructs the bowel and prevents any defecation whatsoever. And usually you have to go in and either treat this with an enema or surgery in some cases. On the other hand, Hirschsprung disease has a different pathogenesis. It's related to a failed migration of neural crest cells to the distal colon. And what happens is because you don't have these neural crest cells, you lose those myenteric neurons that I've been talking about that are responsible for motor movements like peristalsis. And if you don't have peristalsis, just like we saw with toxic megacolon, you get the same megacolon and Hirschsprung disease. So let's talk about what happens here. This is our embryologic GI tract where we have our foregut, midgut, and hindgut. Normally, the neural crest cells migrate. So they start in the foregut and they start migrating down the GI tract and everything's fine. In Hirschsprung disease, however, they fail to migrate 100%. And because of that, we have a specific region like right here that's not going to have those myenteric neurons. So if this is our lumen, mucosa, submucosa, muscular layer, and serosa or adventitia, we know that we have our third layer is our muscular layer, right? So you have your circular layer, and we have our myenteric plexus, which we've talked about now many times as being the nerves that supply peristalsis. And then you have your outer longitudinal layer. And just remember that the myenteric plexus also regulates sphincter tone. In this case, we're talking about the importance of peristaltic contractions when it comes to the myenteric plexus. So when you lose that, just like our ulcerative colitis complication here, it's the exact same thing where you lose peristalsis in one area because of damage to the myenteric plexus, and that'll cause a backup and a distension proximal to that area. And as you can see, I didn't change much. I have the exact same image. It's failed migration of neural crest cells that cause nothing here, and ultimately you're going to get distension proximally. The risk factors for Hirschsprung's important ones to know are the RET gene mutations, and the really important one to know is its association with Down syndrome. This can also present as a failure to pass meconium. You'll get obstructive symptoms like you'd expect, abdominal pain, distension, and bilious emesis. And then you might get chronic constipation as well. Sometimes they'll give, I don't know if they give you it too often on tests, but I think I had a practice problem where a child had chronic constipation and he ended up having like partial Hirschsprung as the answer. So when you evaluate this, there's a classic description of a squirt sign on physical exam where you, let me see if I have it. Yeah, right here. So it's basically you do a digital rectal exam and nothing's wrong, but as you pull out of the anal canal, there's going to be an explosion of feces due to changes in pressure. On x-ray, you're going to see a dilated bowel with no air in the rectum, and you'll also see toxic megacolon like we showed earlier. Here's another picture of it. You can see right here. This whole region that I just highlighted appears to not have received myenteric neurons, so it can't facilitate peristalsis. So you can see how everything proximal to it is getting like very distended. So the gold standard to diagnose this is actually through a rectal suction biopsy, and that will show you an absence of ganglion cells, which makes sense because there's no migrating neural crest cells in that area. And to treat this, you need to treat the affected area by removing it surgically and then connecting or anastomosing healthy bowel segments.
Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.